So I'll be talking on Masquerade Syndrome in uveitis, the tumors appearing as uveitis. So I'll be talking about clinico-pathological correlation of Masquerade Syndrome. Masquerade Syndrome can be neoplastic and non-neoplastic. I'll be talking about neoplastic Masquerade Syndrome in uveitis that comprises of 2.5 to 5% of the uveitis, mostly in the posterior segment. I'll straight go to a few cases. First case is a case which I've seen about 20 years back, 8-year-old girl, persistent hypopyon uveitis, not responding to the topical and systemic steroid. At this point of time, I took help of my seniors who said that, why don't you go into the anterior chamber, and took into the fluid. We did that, and we found basophilic cohesive cells with hyperchromatic nuclei and scanty cytoplasm. This is obvious of a case of a retinoblastoma. Final diagnosis was retinoblastoma, which presented as pseudohypopyon. The second case is also interesting. It's an 11-year-old male child. We don't suspect retinoblastoma in the 11-year-old male child. Dimness of vision in the right eye for 5 months and redness for 2 months duration. Vision was less, 660 and 36 in the right eye. And if you look at the anterior segment, intraocular pressure was raised, fundus and heady blue. And what we found in the anterior chamber, there are organized exudative mass as well as the dusting of the cornea with exudates. This patient, and the slit lamp examinations, whole cornea is studied with exudates. At this point of time, we did ultrasound of the right eye. It did not show retinoblastoma, clear media with attached retina. But UBM showed a medium reflective ciliary body mass with the 3.6 millimeter from 3 o'clock to 6 o'clock. We suspected at this stage there is something wrong and there might be tumor in the eye, and retinoblastoma was our first diagnosis. We did that enucleation of the right eye due to that extensive involvement of the anterior chamber, and we were correct. It was an undifferentiated retinoblastoma, and undersurface of the cornea, anterior chamber, iris, trabecular measure, and ciliary body is involved. Retina choroid is optic nerve is not involved, and you can see this is the cornea, and you can see the posterior surface of the cornea is studded with the tumor cells, and you can see the tumor cells in the anterior chamber as well as the ciliary body involvement. This is a diffuse dusting of the corneal endothelium by retinoblastoma cells is very unique, and we reported in this case report. So anterior segment masculine retinoblastoma, a few words, usually diffuse infiltrating type of retinoblastoma, around 6 years of age, non-familiar, unilateral, often fundus view is limited by anterior chamber exudate, vitreous hemorrhage, or vitritis. Most of these cases, interestingly, do not show calcification on ultrasound, which produces a diagnostic dilemma. Our third case is not my case, it's from PGI Chandigarh, 6-year-old girl diagnosed as a case of acute lymphoblastic leukemia and presented as a hypopyon, and peripheral smear showed a large immature lymphoblast suggestive of leukemia, and this patient restarted chemotherapy but died within a few weeks. What is a pseudohypopyon in a child should not be taken loosely, and is a red flag sign of malignancy. Case 4 is a posterior segment. This one is a tumor lesion. 55-year-old man developed bilateral hypopyon, and Sudarshan has seen this case, and his peripheral blood count to routine examination showed chronic myeloid leukemia. Blood smear, I'll show you, showed myoblast cells, and this patient was found to be having a chronic leukemia. And this is a thing called, when you see a bilateral hypopyon without inflammatory signs in elderly, you think of malignancy. This we have published, bilateral hypopyon as a presenting feature of chronic myeloid leukemia. Case 5 is also quite interesting. This patient I have shown you many times is presented as a choroiditis kind of lesion, was thought to be a tubercular choroiditis. And then when he came to that one, we found leopard skin-like appearance. We thought that is not a choroiditis, and we did that vitreous biopsy, which was negative. Subsequently, with a strong suspicion of lymphoma, we did the fine needle aspiration biopsy, which showed lymphoma. 6 months after, patient indeed developed CNS lymphoma. This is a story of another patient, 51-year-old lady, who came with a blurring of vision and floaters, and this patient had this multiple choroidal nodules. This patient gave history of having contact with the TB, at joint pain with fever. The clinicians thought there is a tubercular chorioretinitis, went ahead and did PCR for MTB done, which was negative. We suspected a primary intraocular lymphoma, but vitreous biopsy showed inflammatory cells. MYD88 also negative. FNAB done, which showed atypical lymphoid cells, and immunohistochemistry showed CD20 positive. Intravitreal injection rituximab given, and the patient responded to treatment. I'm just showing that the FNAB specimen, you can see the necrotic background, which is very characteristic of lymphoma with a large lymphoid cells over here. This is a cell block showed. This necrotic background is multiple pleomorphic lymphoma cells with hyperchromatic nuclei and scanty cytoplasm. CD20 was positive, which is a B cell marker, and suggesting of is a B cell lymphoma. MRI brain was normal. PET CT scan at this stage was no metastasis. The patient had another eye lesions developed as a choroidal nodule, and we did that OCT, and this showed that the subretinal pigment epithelial deposits. Another case is a diagnostic dilemma. This is a solitary lesion, but this time we didn't do the biopsy. You could see that the patient has typical lesions of that leopard skin type of the lesion. OCT showed lymphoma. The patient is given an intravitreal rituximab injections after vitreous biopsy. Primary vitreoretinal lymphoma can present with the floaters and decreased vision, often missed as intermediate uveitis and choroiditis. Many of the times they thought, many people think there is a tubercular choroiditis. Fundus autofluorescence can show granular hypofluorescence, and FFA showed initial phase granular hypofluorescence state, and subretinal RPE for pre-RPE infiltrates and seen at the hypofluorescence. So how to diagnose? Vitreous biopsy, FNAB, and chorioretinal biopsy should be done when as the lesions is that one in the serial order. So first vitreous biopsy, then vitreous FNAB, and subsequently if negative chorioretinal biopsy. Vitreous biopsy, one of the important thing is the specimen should reach path lab within half an hour, because the tumor cells are very friable and necrotic. And if necessary, vitreous biopsy is negative, we can do for a fine needle aspiration biopsy. If negative, one can go to the retinochoroidal lesions to a retinal or chorioretinal biopsy. This can be helpful in some situations, infectious as well as the malignant origin to lesion. So what we do that one, we do the cytopathology, cell block, histopathology of the tissue section, immunohistochemistry with T and B cell marker, interleukin, IL-10, IL-6 ratio, and lastly MYD88L265 mutations. So IL-10, IL-6 ratio is increased more than 1.0 is suggestive of primary vitreoretinal lymphoma if you have got the facility. What's new is that MYD-L265 mutations in intraocular lymphoma, its sensitivity is 88.9% in our hand and specificity is 91.6%. So when you diagnose a lymphoma, it's imperative that you do a MRI brain to rule out CNS lymphoma. So high degree of clinical suspicion is important. Multiple biopsy and expert cytopathologist is required in diagnosis of Masquerade syndrome. Thank you very much. As pathology is there, so our practice in uveitis can improve. Thank you.